Okay, our last approach, and you're probably saying, "Phew," is just to look at some, common terms that are used in oncology, the kind of things that sort of clinicians are working at, sort of the logistics of how this is all kind of coordinated. So you may hear different terms used: induction, adjuvant, consolidation, maintenance therapies, and we'll sort of make some definition of terms here. Induction therapy is the first course of usually high dose chemotherapy with the goal of really improving response or augmenting future surgical or radiation therapies. It's often the first dose that may be a higher or set of doses in cycle one. And keep in mind that many times patients will get cycles of chemo. So they come in on a Monday of week one and they get whatever the regimen is, combination, one or more drugs, typically more than one, usually 2, 3, 4. Before they get their first dose, they're getting their antiemetic therapy. If there's hypersensitivity involved, they're getting acetaminophen and Benadryl and maybe, you know, uh, an H2 blocker, perhaps, though rarely, corticosteroid or something else. Then they're getting their sequenced drug 1 infused, drug 2 infused, drug 3 infused if they have one or more. They're monitored by the team. They sit in the chair. They might be there for 3 or 4 hours getting all of this. And then they're sort of sit and wait to make sure there's no serious adverse events before they're sort of cleared to go back home. These patients always, when they get their chemotherapy, are having someone else transport them. They're not appropriate to be, coming in for their chemo without somebody else bringing them in and without going home with that. So induction chemotherapy is their first cycle. So they get their cycle day 1, cycle 1 day 1, cycle 1 day 2, cycle 1 day 3. Then their next cycle might not be for 21 or 28 days. Typically, it's a 21 or 28 days before their second cycle starts. So calendars go for these cycles. They're very specific for cycle 1, day 1, cycle 1, day 2, cycle 1, day 27, cycle 1, day 28 is the day before their cycle 2, day 1, if it's a 28-day cycle. So it's all kind of, the nomenclature is very specific about how that's done. And the first cycle is typically called the induction cycle, which is the one that often is a higher dose to kind of get the initial response to the cancer chemotherapy, maybe the most toxic of all of them. Adjuvant chemotherapy refers to when you're giving therapy around a surgical intervention, either before or after a surgical intervention, typically after a surgical intervention, where you're doing a surgery and then it's doing mop-up. So this would be particularly done if there was a question that the surgeon didn't get the entire tumor because it went beyond the margins of where they could resect, or for the type of cancer for which metastasis is more common, or there's a risk for that. So it's pretty common to do adjuvant chemotherapy, for example, even with breast cancers where you do surgical intervention, you may do adjuvant chemotherapy around that as well. Neoadjuvant refers to when, it's like adjuvant, except it's given prior to surgery. And it's given in a sense to help shrink the cancer tumor in advance of surgery, so the surgical procedure may be more effective. And it depends on the type of tumor, and I have to tell you, I know nothing about this. Consolidation is once you refer to someone's in remission, the intent is to sustain remission. So it's often, the term is often interchanged with a maintenance chemo, which is the next term we'll use, but it's used to sustain a remission in a patient who's already got therapy. It's sometimes called intensification as well. Maintenance refer to lower doses to assist with a prolonged remission for certain types of cancers where somebody may be on maintenance therapy long term. And a lot of the maintenance chemotherapy these days might be oral. And some of these therapies, very specific therapies, we looked at immunologic specifically, might be oral daily doses of drugs as opposed to coming in for cycles of intravenous or parenterally administered drugs. The we determine what's first line or second line, and that is in part related to tumor markers, related to staging of the tumor, related to the patient's history, their comorbid states, all of these things. And then this evolves over time. So as a patient is registered in a tumor registry, that patient benefits from the experience of anyone else who's been registered in that tumor registry for the prior months or years. Um, for what's worked for the prior patients with those tumor markers, with those staging, with those situation. And then we consider, based on all of that evidence right now at this point in time, this combination of regimen, this combination therapy, and this sequence is first line or second line for this patient. It may be counterintuitive to think of palliative chemotherapy. Palliative chemotherapy is where you pretty much recognize that you're not going to cure anything. You're not going to put somebody into a long-term remission with a good 5-year survival track record. But the chemotherapy may shrink the tumor so it's not invading in surrounding tissue and can then improve symptom management for that patient. So that is sometimes done when the tumor mass and burden is large and there's a lot of symptoms for that patient. So making the decision to treat, always a decision of what's the risk and what's the benefit. And really that's a mixing of what are the patient's values, what are the patient's concerns, what's the family concerns to some degree, what's the health status and general outcome for the patient, what they could tolerate, and what is the clinician and the oncologist understanding of the nature of that cancer, the staging of the cancer, and how likely is that intervention going to offer benefit or not. So to make this decision, we're also looking at the health status and performance status of patients, which cancers response to which interventions, and how you kind of quantify that. In adults, one of the common sort of things that a clinician would look at in evaluating their availability of going through chemo is not only where their cancer is and where it's staged, but what's the performance status of the patient? Are they ability to carry on normal activity, or are they compromised? Do they have comorbid states, or is the cancer sort of advanced so much that their ability to mount a response and tolerate the chemotherapy is limited? So that's an important decision to make, and it's done sort of in conjunction with the values of what the patient has, and you really need to make sure the patient's values are really addressed what they want. And I think the issues that clinicians look at is both quality as well as quantity of life. So those are big issues that have to get addressed with the oncology team in conjunction with what the patient, with good information, what the patient would want. You don't want the patient just to say, hey, doc, what would you do, without the values of the patient being sort of probed of what's important for this patient. In children, there's also performance. In pediatric cancers, there's also a performance scale that's used as well, the Lansky performance scale. There might be other scales that are used as well. This is an older scale, but might be there. The next couple of slides, I get heartburn when I see these slides because these are abbreviations that can easily lead to a medication error. And if there's ever a time when I'm worried about med errors leading to serious consequences or death for a patient, it's chemotherapy and oncology. So here are some commonly used abbreviations for treatment regimens that I have heartburn over when I see them used. I'm not fully familiar with these regimens, but these abbreviations, in my mind, unfortunately, are still sometimes used. You want to really be clear, though, that whenever you're talking about a particular chemo regimen, every clinician knows exactly what we're working with and what the treatment plan is, and that the treatment plan is double and triple independently checked by every clinician who's involved with this patient. So that's typically done with the oncology team with independent checks by the oncologist, maybe a PA or an NP that might be working with an oncologist, with the nurse who's administering it, and the pharmacist who's preparing the medication. All of those do independent checks, and there's a treatment plan that is specifically outlined that says this goals of therapy and this patient's following this treatment plan. that is per the protocol of this tumor registry that this patient is registered with or whatever, and that we don't like to use these abbreviations, but the treatment plan outlines very specifically what the agents are, when they're cycled, when they're used, when there's a dose reduction, what kind of things we look at. So here are some common regimens. Probably the one that people would have the most familiar with is CHOP near the bottom, cyclophosphamide, uh, uh, doxorubicin, vincristine, and prednisone therapy. There's some more that's listed here. Again, not a focus, I think, for many of us who don't work in oncology, and even concerning for those who do, is the abbreviations really the best way to approach these. Another set of abbreviations, and a final set of abbreviations. Sort of as somewhat of almost a wrap up, let's look at a couple of common examples of what sort of approaches might be. And I'm going to take this from the perspective of this is now a little dated from a little year and a half ago, maybe 2 years ago, for the kind of management of non-small cell lung cancers or breast cancers. But I think what it's helpful here, even if it's a little dated, it kind of goes through the clinicians' approaches to managing a cancer and what goes through clinicians' minds. So for non-small cell lung cancer, typically you want to look at what are the tumor markers or genetic mutations that are there in the tumor cell that help document sort of what baseline data do you need? What are you dealing with that are markers to know what is targetable versus what is not targetable for which kinds of therapies that you would look at or intervene with. And so this chart kind of helps a clinician do that. Then you look at what the immunologic trials have indicated as first-line or second-line therapies for the type of advanced stage lung cancer the patient has and what the track record is there. You'd also look at what are selected first and second line therapies from other studies. These are done in conjunction with the tumor registries to determine which regimens, which agents are used. And with breast cancer, pretty similar. Breast cancer, we're going to determine breast cancer is it metastatic or not? And then other considerations we're going to look at is what their risk factors are they premenopausal or postmenopausal? And that indicates the role to which in breast cancer we're going to use something that's going to target estrogen. So we're using an aromatase inhibitor, are we using tamoxifen, are in conjunction with chemotherapy or immunologic therapy. So the endocrine therapy options really look at first line, where does aromatase inhibitors fit versus where does tamoxifen fit. And then the adjuvant or perioperative or preoperative chemotherapy for folks with certain localized early stage breast cancers, which therapies are pre-adjuvant or adjuvant therapy, are sort of listed here with the older chemotherapeutic agents that are still used in conjunction with the, what we talked about earlier, either the aromatase inhibitors or the tamoxifen therapy. And we're looking at here is again more data for adjuvant therapy for early or localized cancer, breast cancer. Then in the metastatic disease, there's data to say which chemotherapeutic agents have a role in what kind of dosing for HER2 negative or positive breast cancers. For HER2 positive breast cancers, combinations are listed here. And then the novel therapies for breast cancer looks at some of the specific receptors that are done with the monoclonal antibodies or the other immunologic therapies and where they fit, depending on certain receptor sites that are targeted. Again, here are more receptor sites that are specific to which types of cancer. Again, more receptors configured to which types of cancer. And finally, more receptors and which type of agents make sense. So, in a nutshell, we've gone through a lot here, but I think you see a broad picture of how the oncology team manages it. And then what are the kind of things you as a clinician are going to see when you inherit these patients and what do you need to monitor for?